Thank you, Mr. Chairman. That's my disclosure statement. We do know the combination therapy of alpha blockers with antimuscarinics is now a recommended treatment option for patients with benign prostate enlargement who suffer from OAB symptoms as well. We also know that all 5 muscarinic receptors have been identified both in the bladder and in the prostate, but the role in PPE OAB is yet unclear. Previous studies have indicated that alpha blockers have a direct effect on blood vessels, improving prostate perfusion and reducing oxidative stress markers. But it is unclear if antimuscarinics affect prostatic perfusion. So here we conducted a pilot study where we tried to assess prostate vascularity before and after Tamsulosin monotherapy and a combination with anticholinergic treatment. So this is the study design. We recruited patients with at least 30 mils of prostate with storage symptoms higher than voiding symptoms in the IPSS, with at least 3 urgency episodes per 3-day bladder diary, with at least a score of 3 in the urgency question of IPSS. And they were randomized to either monotherapy with Tamsulosin AUCAS or with Tamsulosin AUCAS and 5 milligrams Solifenacin, which could be titrated to 10 milligrams after 4 weeks of treatment. And this is the study design. You can see it's a 24-week, 26-week study where patients were assessed with all these measures and with TRUS and urodynamic investigation and a biochemistry at beginning of study, but also at the end of study. This is the ultrasonographic method used. There was a sequence of Doppler images from prostate apex to the base on a 5 millimeter step basis using a stepper. There was then these data were actually put into a planimetric volumetry model with a manual delineation of visible vessels and pixel calculation of the selected area. This was a 3D prostate model which was created for the volumetric measurements already by Kojima. So then the color pixel density is the percentage of vascular surface to the total prostate volume, as you can see. And this is the statistical analysis. We recruited 80 patients, out of which 69 were randomized, 34 in group 1 and 35 in group 2. And after all, 31 and 32 patients completed the study. Both groups were comparable in terms of baseline characteristics: age, BMI, frequency, urgency, episodes, total IPSS, storage and voiding symptoms, subscores, prostate volume, maximum flow, PVR, and color pixel density. And these are the results. There was a 149% increase in the color pixel density that corresponds to 1.9% of total prostate vascular surface in the monotherapy group. But there was also a 9% increase in total prostate volume and a 70% increase in adenoma volume, as opposed to an almost 20% reduction in color pixel density that corresponds to 1% of total prostate vascular surface in the combination group, and a 9.5% reduction in total prostate volume and 12% reduction in adenoma volume. How can we interpret those results? With difficulty at the moment. They suggest actually that Tamsulosin monotherapy positively affects the perfusion of prostate gland, as previously shown in other studies, while antimuscarinics seem to reduce the gland's perfusion. And the changes seem to be proportional to volumetric changes of the prostate and the adenoma in both groups. And whether antimuscarinics cause prostate ischemia leading to reduction of the prostate and adenoma volume remains to be further investigated, as well as possible associations of these morphometric changes of the prostate with symptomatic improvement. Thank you very much for your attention.
So any questions from the floor? Looking at this, I did wonder if, given that the alpha blocker causes a vascular increase in perfusion, do you think the increase in prostate volume is simply because of the increase in vascular perfusion, so everything is just a bit more congested? Or is that too simplistic?
Maybe. I think, we know that sympathetic mimetic drugs can actually help increase the volume of the prostate, and also in prostate cancer cell lines it has been shown. So whether it's only a vascular or a neurogenic effect as well, I think it's possibly a combined effect. But that's
could it be the converse? Could it be that you're not necessarily getting increased perfusion, but the prostate's got bigger, therefore there's more vascular tissue for you to pick up in your testing?
Not really, because we did it in percentage of the total volume. So I think it's
so individual vessels got bigger. Oh, one other question from the floor. Mr. Finney.
Hi, Steve Finney from the UK. Potentially, you've got quite a heterogeneous group with the combination arm. I presume the decision from 5 to 10 milligrams of solifenacin was based on clinical benefits. Did you do any analysis between differences between the 5 and the 10 milligrams?
Yes, there were no statistical differences between the two, but actually there was only 7 patients who actually titrated 10 milligrams, so we cannot really make any safe conclusions on that.
There wasn't any glaring differences?
Sorry.
Perfect, thank you.
Okay, if there are no other questions, thank you very much.
Thank you.